We'll talk today about hypertension, and first we'll talk about the causes of hypertension. Two main groups of hypertension causes. First one, essential hypertension or primary hypertension, and it accounts for about 90 to 95% of cases. And other causes is secondary causes of hypertension, which we can group into causes due to renal disease such as polycystic kidney, renal artery stenosis, or diabetic, and for example also glomerulonephritis patient can develop hypertension. Cardiovascular causes like coarctation of the aorta, we would find hypertension in young patients complaining from headache, and on examination we find the signs of coarctation of the aorta like radiofemoral delay. Endocrine causes of hypertension like pheochromocytoma, which we will find headaches, episodic in attacks associated with episodic or intermittent hypertensive patient, associated with palpitation, flushing. All these symptoms are intermittent. We could also think about other causes of endocrine disease like Conn's syndrome, which we find hypertension associated with low potassium level and high sodium due to overproduction of aldosterone hormone. Cushing syndrome also can be presented with hypertension. Signs of Cushing will find the patient is obese, central obesity, and excessive facial hair growth. And on abdominal examination, we'll find by inspection abdominal stria. There are some drugs associated with high blood pressure, like hormone contraceptive pills, non-steroidal anti-inflammatory drugs. Here, how we classify essential hypertension. For most patients, target blood pressure would be 140 over 90 millimilli mercury. More than that, we diagnose mild hypertension, and severe hypertension will be with figure more than or equal 180 over 110. We start the treatment if blood pressure more than or equal 160 over 100 in moderate stage. For all patients should be offered treatment. In the mild stage of hypertension, while blood pressure more than or equal 140 over 90, we offer treatment to patients under 80 years of age with other risk factors like target organ damage, which we can find on the eye with retinopathy, heart, cardiomegaly, or any risk heart disease, and renal affection in the form of proteinuria or diabetic patient. Also, we can offer treatment early. And if we find the 10 years risk of cardiovascular risk more than 20%, more than or equal 20%, which will be find, you can access the cardiovascular risk by logging to this website, which will give you the risk. If more than or equal 20%, so we can start the treatment in blood pressure more than or equal 140 over 100. First, in the early stage of hypertension, we offer lifestyle modification such as decrease salt intake, limited alcohol consumption, for example, to be less than 21 units per week for men and less than 14 units for women. We can advise the patient also to have regular exercise. Other important approach is giving patient statin to reduce the overall cardiovascular risk, and also glycemic control should be optimized in diabetic and with hemoglobin A1C less than 53 millimole. All these are lifestyle and corrected risk factors which we can approach before starting or with starting medication. And another important risk factor we can ask a patient to stop smoking, and he can also try to, with exercise, to lose some weight. And the medication we can use is A, refer to ACE inhibitor or angiotensin converting enzyme receptor blocker, B, the beta blocker, C, calcium channel blockers, and the diuretics. And now we have approach this guideline to choose your medication. So for patient less than 50 years age, we start with A, angiotensin converting enzyme group, and we check patient after that. If he has no response, we go to stage 2 to add also C, which is calcium channel blocker. So we start with ACE inhibitor, and we can add calcium channel blocker to patient if there is no response. All these to patient before less than 50 years old. And stage 3, if it's still uncontrolled, we can add diuretics to the regime. For patient who is older, more than 50 years, or of African or Caribbean origin, we start with the calcium channel blocker because these patients are genetically resistant to ACE inhibitor. So we start with calcium channel blocker. If no response, we can add ACE to this patient. And in the stage 3, if there is still resistance to treatment, we can add diuretics. So we can use this diagram in the exam situation, because some scenarios in the questions come with this diagram. In stage 4, after we try ACE inhibitor, calcium channel blockers, and diuretics, and there is no response, we can add another diuretic, or we can add alpha blocker or beta blocker, or if there is resistant and difficult case, we can seek expert advice. So now I will show you some scenarios for questions in the exam. He can give you a scenario of to reach the diagnosis, especially asking for secondary causes of hypertension. So scenario might be for polycystic kidney, giving you some ultrasound picture, polycystic kidney, which is autosomal dominant, and with family history, you can pick the diagnosis. He also can ask about, give you some biochemical parameters and pointing to Cohen's syndrome when you find hypokalemia with hypertension, and ask you what is the possible etiology. Cushing syndrome is the same, also can be asked in the clinical picture. Pheochromocytoma, very common in the exam, giving you scenario of intermittent severe attacks of high blood pressure and asking you how to diagnose the case. Also important scenario is giving you this, asking you about this diagram to show, to see if you are aware of this starting medication for hypertension. He can ask you, for example, 50 years old, a Caucasian female, coming to your clinic and asking which likely drugs to start with. He asks you diuretics, calcium channel blocker. So 50 years Caucasian is A. If he asks you is African male, 60 years age, so we start with C. All these scenarios can come in examination, and good luck.